The average 65-year-old today has a 70% chance of needing long-term care at some point, according to data cited by industry researchers. Medicare, the program most Americans assume will be there for them, does not cover it. Medicaid does, but only for those who meet specific financial thresholds, updated for 2026 in a CMS informational bulletin released this past December. And the planning window the law requires, up to 5 years in advance, means that most families who wait until a crisis arrives have already missed the moment when their options were widest. Today, we decode the exact numbers and the timeline that matters most. I'm Michael Bennett. Welcome to Retirement Watch. Today, we are looking at the 2026 Medicaid financial eligibility criteria for long-term care. The official thresholds, the legal mechanism behind them, and a new piece of federal legislation that could change how assisted living is covered. I am going to give you exactly what the official data shows in plain language, so you can plan ahead of a crisis rather than during one. Many families assume that Medicare will cover long-term care when the time comes, that after a lifetime of paying into the system, extended nursing home or custodial care will simply be there. According to the National Council on Aging and multiple elder law sources, that assumption is incorrect, and it is one of the most consequential misunderstandings in American retirement planning. Here is what Medicare actually covers and what it does not. Medicare primarily covers medical treatment and short-term skilled care. Original Medicare's nursing home coverage is specifically designed for rehabilitation following a hospital stay, not for ongoing long-term custodial care. Here are the specific mechanics. If a patient has had a qualifying hospital stay of at least 3 days, Medicare Part A may cover care in a skilled nursing facility. For days 1 through 20 of that stay, there is no copay. For days 21 through 100, the patient pays a daily coinsurance, $217 per day in 2026, up from $209.50 in 2025. Beyond day 100, Medicare coverage ends entirely, and the patient is responsible for all costs. What Medicare does not cover is what most families actually need help with: long-term custodial care, assistance with activities of daily living, bathing, dressing, eating, toileting, continence, and transferring, or supervision due to cognitive impairment. So who actually pays for this kind of care? The estimated median cost for nursing home care in 2025 was $9,555 per month for a semi-private room. And that figure varies significantly by state, with some states estimating average monthly private long-term care costs closer to $12,216. Many people start paying for this kind of care out of personal savings or private long-term care insurance. But for the majority of Americans who eventually need extended care, Medicaid becomes the primary payer. Medicaid is described as the largest single funding source for nursing home care in the country. Here is the critical distinction most families do not understand until they are in the middle of a crisis. Qualifying for Medicaid is not automatic, and it is not based on need alone. It requires meeting specific financial criteria, both income and asset limits, set partly at the federal level and partly by each individual state. Each year, the Centers for Medicare and Medicaid Services issues an informational bulletin updating the baseline federal figures used in determining Medicaid long-term care eligibility. The most recent bulletin, issued in December of 2025, set the standards effective January 1st, 2026. Those are the facts about what Medicare does and does not cover. Now, let me give you the context that most of what you've seen doesn't include, specifically the legal mechanism that makes timing so important. Medicaid eligibility for long-term care is not simply a snapshot test of your current bank balance. It involves what is called a look-back period, time during which the state Medicaid agency reviews your financial transactions to determine whether assets were transferred or given away specifically to qualify for Medicaid. According to elder law sources, Medicaid planning using an asset protection trust must generally be done well in advance of when care is actually needed. 2.5 years for home care eligibility and 5 years for nursing home care eligibility in most states. Here's the mechanism, explained simply using an analogy. Think of the look-back period like a credit check that examines not just your current balance, but every transaction over the previous 5 years, specifically looking for transfers that appear designed to artificially reduce your countable assets right before you apply for benefits. If the state finds transfers made during that look-back window that exceed certain allowable thresholds, it imposes a period of ineligibility calculated based on the amount transferred divided by the average private pay cost of care in your state. During that penalty period, Medicaid will not pay for your care, even though you have already given away the resources that might have paid for it privately. This is precisely why the timing of any asset transfer or trust establishment matters so significantly. A family that begins planning 5 years before care becomes necessary has tools available, including Medicaid asset protection trusts, which legally shield assets from being counted toward eligibility, that are simply unavailable to a family that begins planning only after a parent has already been admitted to a nursing facility. Now, I want to address directly the specific protections that exist for a spouse who remains at home while their partner requires nursing home care. Without specific protections, a couple facing a long-term care need could see virtually all of their joint assets and income required to go toward the cost of the institutionalized spouse's care, potentially leaving the at-home spouse, sometimes called the community spouse, without sufficient resources to live on. Congress addressed this directly through spousal impoverishment protections, which set aside a specific protected amount of income and assets for the spouse remaining at home. The first protection is called the Minimum Monthly Maintenance Needs Allowance, abbreviated MMNA. This is the minimum amount of monthly income the at-home spouse is guaranteed to keep. For 2026, the federal minimum MMNA is $2,643.75 per month, and the federal maximum is $4,066.50 per month. Here's a concrete illustrative example of how this works. Consider a hypothetical couple. Let's call them Frank and Dorothy. Frank lives in a nursing home with a monthly income of $3,000. Dorothy lives at home with her own monthly income of just $900. If their state's minimum MMNA is $2,643.75, Dorothy is entitled to receive $1,743.75 transferred from Frank's income, because that amount plus Dorothy's own $900 equals exactly the protected minimum. The second major protection is the Community Spouse Resource Allowance, abbreviated CSRA. For 2026, the federal minimum CSRA is $32,532, and the federal maximum is $162,660. The third protection involves the home itself. A primary residence is generally treated as an exempt asset for Medicaid eligibility purposes, but only up to a specific equity value. For 2026, the minimum home equity limit is $752,000, with some states permitting limits up to $1,130,000, and a small number of states, including California, having no home equity limit at all. I want to note something important here. While these are the federal baseline figures, Medicaid is jointly funded and administered by federal and state governments, and states have meaningful discretion. The standard resource limit for a single applicant remains frozen at the historic $2,000 threshold in the overwhelming majority of states, but several states have set significantly higher limits. Maine has raised its asset exemption to $10,000 for individuals. New York's limit is approximately $33,038. Illinois sets its limit at $17,500. This state-by-state variation is precisely why two families with nearly identical financial circumstances can face entirely different Medicaid eligibility outcomes depending solely on which state they live in. Here's what this means in plain language for someone in your situation. If you are part of a married couple where one spouse may need nursing home care while the other remains at home, the spousal impoverishment protections I just described are specifically designed for your situation. Understanding your state's specific MMNA and CSRA figures is essential before any application is submitted, not after. If you are a single applicant with assets close to your state's resource limit, the gap between states matters enormously. A single applicant in a standard state faces a $2,000 asset limit. The same applicant in New York faces a limit roughly 16 times higher. If you are considering an asset protection strategy and have not yet consulted a Medicaid planning professional, the 5-year look-back period means that time is the single most valuable resource you have, and it is not renewable. Let me walk through a specific illustrative example to make the look-back mechanism concrete. Consider a hypothetical individual. Let's call her Carol, a hypothetical 78-year-old widow with $150,000 in countable assets who has not done any Medicaid planning. If Carol's health declines suddenly and she needs nursing home care within the next 12 months, any significant gifts or transfers she makes now would fall within the 5-year look-back window if she applies for Medicaid in the near future. If Carol gives away $60,000 to family members and then needs to apply for Medicaid within 5 years, her state would calculate a period of ineligibility based on dividing that amount by her state's average monthly private pay nursing home rate. If that average rate is roughly $10,000 per month, Carol would face approximately 6 months during which Medicaid will not pay for her care, despite no longer having the money to pay for it herself. Now compare that to a hypothetical individual who began planning 5 years earlier. Let's call him Walter, a hypothetical 73-year-old who consulted an elder law attorney and established a Medicaid asset protection trust 5 years before any care need arose. Properly structured and properly timed trust transfers fall outside the look-back window entirely by the time care becomes necessary, meaning Walter's protected assets are not counted against his Medicaid eligibility and do not trigger any penalty period. The difference between Carol's situation and Walter's situation is not the amount of money involved. It is entirely the timing of when planning began relative to when care became necessary. Now, let me address a forward-looking development that could change part of this picture, the Access Act. In late April 2026, Senator Roger Marshall, a Republican from Kansas, introduced the Assisted Living Affordability, Choice, Community, Empowerment, Savings, and Support Act, known as the Access Act. The bill would make assisted living a covered Medicaid benefit for older adults who meet nursing facility level care criteria for the first time at the federal level in this specific way. Senator Marshall's stated rationale, in his own words, Medicaid spending is on an unsustainable path, and too many seniors are being pushed into higher cost care they don't actually need. This bill is about giving states the ability to provide the right care in the right setting while protecting the long-term future of Medicaid. The American Seniors Housing Association, representing the senior living industry, has responded with both support for the concept and specific concerns, noting that creating a new Medicaid benefit for what has historically been a largely private pay model presents both opportunities and challenges. This proposal arrives in a specific budgetary context. Medicaid spending is projected to grow 63% over the next decade, and state budgets are already absorbing approximately $1 trillion in federal Medicaid spending reductions enacted under H.R. 1, the budget reconciliation law signed in the summer of 2025. Here are three realistic scenarios for how this landscape develops. These are probability estimates, not predictions. Scenario A, approximately 25% probability. The Access Act or a similar measure advances and expands Medicaid coverage to include assisted living in at least some states. Scenario B, approximately 55% probability. The current system continues largely unchanged, with annual adjustments to the federal baseline figures continuing the established pattern. Scenario C, approximately 20% probability. Continued budgetary pressure leads some states to tighten eligibility criteria or reduce optional home and community-based services, even as core federal eligibility thresholds remain stable. Here are the markers to monitor. Watch for CMS's annual informational bulletin, typically released in December, setting the following year's federal baseline figures. Watch the progress of the Access Act and its House companion bill through committee. Watch state-level budget decisions regarding home and community-based services, and watch for any updates to your specific state's resource limits. Before I let you go, here is what you can actually do with this information. First, contact your local state health insurance assistance program, State Health Insurance Assistance Program, or SHIP, for guidance specific to your state's Medicaid rules. Find your local state health insurance assistance program or SHIP at shiphelp.org or call 1-877-839-2675. Second, if you believe a long-term care need may arise for yourself or a spouse within the next 5 years, consult a qualified elder law attorney or certified Medicaid planner now, rather than waiting. Third, verify your specific state's current Medicaid resource limits directly, since they can differ significantly from the federal baseline. Your state Medicaid agency's contact information is available through Medicaid.gov. Fourth, if you are part of a married couple and one spouse may need institutional care, specifically ask about your state's current minimum monthly maintenance needs allowance and community spouse resource allowance figures. Fifth, if you want to track the Access Act's progress, the bill can be followed directly at congress.gov. I am not providing financial, legal, or tax advice. These are official resources for your own research, and given the complexity and state-specific nature of Medicaid planning, working with a qualified professional in your state is strongly advisable before making any asset transfer or trust decision. Here is the bottom line. Medicare does not cover long-term custodial care. Medicaid does, but only within specific financial thresholds that were updated for 2026, a standard resource limit of $2,000 in most states, with notable exceptions, a community spouse resource allowance between $32,532 and $162,660, a minimum monthly maintenance needs allowance between $2,643 and $4,066, and a home equity limit starting at $752,000. The legal mechanism that matters most is timing, a 5-year look-back period that rewards families who plan years in advance and penalizes those who wait until a crisis forces the question. A new federal bill, the Access Act, could eventually expand Medicaid to cover assisted living specifically, though its path through Congress remains uncertain. If this gave you something clear that you didn't have before, consider sharing it with someone in your life who is planning for a parent's care, or who has not yet thought through what happens if long-term care becomes necessary. I'm Michael Bennett. Thank you for watching Retirement Watch, helping seniors understand their benefits.